All right, thank you for joining, everyone. I'll hand over to Ann Greiner and Mark Del Monte.
All right. Good morning, everybody. I hope you can hear me okay. Give a thumbs up. Very good. Welcome to today's very important webinar. I am excited to be here and thank you for joining us. I want to thank everybody who's online watching, particularly the members of the media that are here. We're delighted to have you. My name is Mark Del Monte. I'm the CEO of the American Academy of Pediatrics, and I'm also chair of the board of directors of the Primary Care Collaborative. Welcome to today's report release. This is called the PCC 2022 Evidence Report, Relationships Matter, How Usual is Usual Source of Primary Care. This event is presented by the Primary Care Collaborative, which is a nonprofit membership organization of 68 organizations committed to the mission and to the shared principles of primary care, which more than 350 organizations have signed on to. The PCC is a multi-stakeholder organization that unifies and engages stakeholders, promotes policy, shares best practices, all in order to support the growth of high-performing primary care. The PCC is dedicated to advancing an effective and efficient health system built on a strong foundation of primary care and the patient-centered medical home. The PCC also hosts great meetings, which are always inspiring and educational, and I would urge you to attend this year's meeting on December 14th and 15th in Washington, D.C. There'll be a link for you in the chat, and it would be great to see you there in person. Let me give you a few housekeeping reminders there. The report itself is now available on the PCC website at the URL that's being put into the chat. We hope you'll take some time to read it after this hour webinar and after you've had an introduction and some analysis of it. All lines for the participants are automatically muted, but we welcome your questions, so submit those questions in the questions box. All the questions from the audience will be addressed after the panel discussion, but you can submit those questions at any time. This webinar is being recorded, and the recording and the slides will be posted on the website within 48 hours, sorry. Let's begin. Each year, the Primary Care Collaborative produces an in-depth report that analyzes a timely primary care topic and provides relevant data and evidence. This is the 11th annual evidence-based report produced by the PCC. This year's report has been made possible by a number of organizations who provided financial support, including the AAFP Foundation, the American Board of Medical Specialties, the American Board of Internal Medicine Foundation, and the American Academy of Physician Assistants Foundation. This report is particularly timely, as primary care is in the spotlight. First, there is increased interest from leaders in leveraging primary care to get the country back to higher levels of physical and mental health after 2+ years of the COVID-19 pandemic. And second, there are copious amounts of capital pouring into primary care as innovators seek to reinvent this valuable but vulnerable foundation of our nation's healthcare system. Leaders are also looking to primary care to help close widening equity gaps by establishing trusted relationships with patients and community partners and providing whole person care that considers physical, behavioral, and social needs. The 2022 PCC evidence report is focused on a key metric, usual source of care, that is at the center of primary care and is the relationship between a patient and the primary care clinician. Unfortunately, as this report shows, this source of primary care, this core of primary care, is stressed. Rates of usual source of care continue to fall. They are far worse for people of color, and there have been troubling declines for more medically vulnerable populations, including those covered by Medicare and Medicaid. This report, which also includes usual source of care rates by state, helps draw attention to a problem that we must collectively fix to get our nation back to better health. We know that we can do better, and we know that we must. So let's get to the report. We'll get a briefing on it and talk about it with a stellar lineup of experts. First, we'll hear from one of the report's authors, who will walk us through the report, Then a panel of experts from different fields will reflect on the implications of the report findings and recommendations, and then we'll take time at the end for questions from the media and the audience. So first up, let me introduce Dr. Yalda Jaberpour. She's a family physician in Washington, D.C., and director of AAFP's Robert Graham Center for Policy Studies. She has worked as a family physician in San Diego, and her research interest includes workforce issues such as provider burnout and the delivery and financing of primary health care. Dr. Jaberpour.
Thank you, Dr. Del Monte. Hi, everyone. It's my pleasure to give you a broad overview of this year's primary care evidence report entitled Relationships Matter: How Usual is a Usual Source of Primary Care. Next slide. So before I dive into the report, I wanted to set the stage as to why we are focusing on usual source of care this year. Usual source of care is the term that is given in research and surveys to someone's regular clinician. And for most people, this means a primary care clinician. And what do we know about having a relationship with usual source of care? In section 1 of the report, we go into a great deal of detail about what it means to have a usual source of care as found in the literature and who has one. And what we find over and over again in the literature is that having a usual source of care is associated with higher quality of care, a higher likelihood of meeting the social needs of patients, lower emergency department use, higher rates of preventive service use and screenings, better control of chronic disease, and less costly care. Next. And because of the obvious benefits of usual source of care, trends in the uptake of usual source of care have actually been studied pretty broadly. Researchers on our team at the Robert Graham Center had looked at this question of who is utilizing usual source of care from 1996 to 2014, previous to writing this report. At that time, we did find a steady decrease in usual source of care. And not only that, we saw that people with the usual source of care were increasingly saying that it was not a particular person that they received their care from, but instead a facility that they were identifying as their usual source of care. And although there was a general decline overall, the rates of individuals reporting a usual source of care did vary at that time based on patient demographics and whether or not they were insured. Next slide. But as we've all witnessed, a lot has changed in healthcare since we last did this study. For example, although the Affordable Care Act was implemented in 2011, it was not until later that there was widespread adoption and expansion, with the potential to drive up demand for healthcare services as more Americans were insured. There was also a growth of high deductible health plans in this time period, which previous work done by us at the Graham Center has actually been shown to keep people from seeking needed care. And as we all know, the COVID pandemic completely disrupted healthcare. So did this drive up demand for a primary care clinician as more patients were seeking care and advice? Or did this keep people away from primary care because of stay-at-home orders, social isolation, and just a growing mistrust of medicine and science? And finally, we have seen a rise of convenient care in the last few years. So did these retail options for care and virtual care enhance the usage of primary care in a long-lasting relationship, or has it resulted in one-off visits and a continued decline in that relationship with the usual source of care? Next slide. With this in mind, many of the same questions we had in our previous study persisted, but with new context. Next slide. Has the decline in usual source of care continued? Did this vary by demographics and insurance type? And something we didn't look at last time, which has become increasingly important in today's world, is whether there were regional differences in uptake. And finally, what, if anything, is the potential impact on health quality given an increasingly widening gap between those who have access to and receive high quality healthcare and those who do not. Next slide. To answer these questions, we relied on 3 data sources overwhelmingly in the report, although other data sources were used. Most of the analysis focused on using the Medical Expenditure Panel Survey, or MEPS, as I'll refer to for short, which is a nationally representative survey of non-institutionalized civilians in the United States. The survey follows respondents over a 2-year period and records information about their healthcare utilization. For the state level findings, we relied on a similar survey called the Behavioral Risk Factor Surveillance System, or BREFIS. And for the findings on usual source of care and emergency department use or hospitalization, we used yet another survey called the National Health Interview Survey. Although these surveys are all different in the types of information they collect, they all ask about usual source of care, making them good sources of information for this report. In this presentation, I'm going to focus on the major takeaways, but please do go to the report as there are many more interesting findings and nuances in there that deserve attention as well. Next slide. I'm not going to go too deep into methodology because I want to get to the results, but I wanted to take a moment to explain how we determined if someone had a usual source of care. In MEPS, the question is asked, is there a particular doctor's office, clinic, health center, or other place that you usually go if you are sick or need advice about your health? If a respondent said no, they were automatically placed in that no usual source of care category. For those that said yes, there is a follow-up location of care question. If they say that the location of their usual source of care is the emergency department, we actually put them in the no usual source of care bucket this time, which we hadn't done previously. Everyone else fell into that usual source of care bucket. So what did we find? Next slide. Overall, we saw that over the last 2 decades, there has been a 10% decrease in a usual source of care uptake. In 2000, 84% of the population reported a usual source of care, and this fell to only 74% in 2019. Interesting, there's a slight increase to 75% in 2020. We can't make any comments on whether this is a trend yet, but it's something to watch in the COVID era. Next slide. One thing that was novel this time around was really looking at regional differences in uptake. Here we used 2020 BREFIS data to look at how reporting of usual source of care varied by state. The darkest blue, almost purple states had the highest uptake, and the lighter states had the lowest uptake. Uptake varied from between 57% of the state's population to 84% reporting a usual source of care. And there are many factors that could be contributing to this difference on the state level, but one of our questions was if primary care supply had anything to do with it. Next slide. So in this second map, we actually overlaid primary care supply in 2020 with usual source of care uptake in 2020. Let me orient you to the map for a second. So if you see that little box down there on the right, that goes over the colors. In the upper right of that box, you can see that the darkest purple means the highest usual source of care and also highest PCP supply. On the other hand, the lower left of that box, you can see that gray means a state is low in both PCP supply and usual source of care uptake. Then there are the exceptions to the rule. If you look at the upper left of that box, you see that red means that there's a high usual source of care uptake, but actually low primary care supply. And royal blue on the lower right of that box means a high primary care supply, but low uptake of usual source of care. So if you turn to the map, we see that the upper northeast, where we saw higher usual source of care uptake, also had a high PCP supply. The states, some states in the west and south had low PCP supply and also a low usual source of care uptake. But then there are those exception states like Kentucky in the red, where there is high usual source of care uptake despite a lower PCP supply, and Alaska in royal blue, where there is low uptake of usual source of care but high PCP supply. So even though primary care supply is one factor for some states, there are obviously other things that are impacting the usual source of care uptake. Next slide. So to look at these other factors, we used the MEPS data to examine patient characteristics associated with having a usual source of care in 2019. This is a busy figure that we dive into much more fully in the report, but here are the take-homes. Compared to patients that are in the 18 to 34-year-old age group, all other ages had a higher odds of having a usual source of care, holding everything else constant. You can see that for those less than 18, this was a 6 times higher odds, and for those above 65, 3 times higher. And this makes intuitive sense, as those in the 18 to 34 age group are generally healthier, so they don't seek out a usual source of care. But also for some of them, namely those above 26, they've fallen off their parents' insurance, and it may be financial barriers to maintaining a usual source of care that's driving this. In addition, many recent reports have shown that this age group in particular really values convenience over continuity, which might explain some of these results. We also see that compared to white individuals, Black and Hispanic individuals are less likely to have a usual source of care. Hispanic individuals are 66% less likely, and Black individuals 38% less likely. And this is troubling, given racial health disparities that already exist in this country. So this is a particular area where we need to understand what is happening and devote resources to correcting this so everyone has a medical home. And finally, we see that insurance does matter as well. Compared to the privately insured, Medicare and dual eligible individuals were more likely to have a usual source of care, and the uninsured were less likely. Some of this may be driven by the fact that Medicare and dual eligibles have higher health needs, but it deserves more attention to see why the privately insured aren't accessing a usual source of care, where preventive services can occur and chronic diseases can be diagnosed early and managed. Next slide. And finally, digging into the insurance a little bit deeper, we do see that compared to 2015, usual source of care uptake has decreased for people with all types of insurance in 2019, including Medicare and the dual eligible. Again, though, in both time periods and actually throughout the last decade, and you can see those results in the report, Medicare has the highest levels of usual source of care and privately insured the lowest. Probably most concerning is the trend in the uninsured, where only a little over a third of this population reports a usual source of care. Next slide. So there are a few overall messages that our literature review combined with this analysis is showing. One, having a usual source of care does lead, we know, to higher quality care, reduced unmet health needs, less costly care, and reduced healthcare disparities overall. The literature has shown that over and over again. Yet the percentage of the population reporting a usual source of care in the United States continues to drop. And for Black and Hispanic individuals, as well as those who are uninsured, the rates of usual source of care are the lowest. Neither primary care supply or insurance coverage explains the likelihood of having a usual source of care completely, so there are other factors at play here. Next steps. Next slide. With any good analysis, we have more questions than answers after doing this. We really need to understand why usual source of care is declining and whether COVID and policy changes or market changes such as expansion of telehealth and retail will change these trends. We need to understand what patients really want from primary care. Is it simply convenience? And this is why there's a continuous relationship is decreasing? Or is it truly that continuous, comprehensive, coordinated relationship that primary care is built on? And does this differ for different patients? And finally, taking us back to the title of our report, if relationships truly do matter to people, how do we restore them and reverse this alarming trend? So thank you very much for your time, and I'm happy to take any questions in the question and answer session.
Dr. Jabarpar, thank you. I think we are all stimulated by the conclusions and the next steps questions. So let's move on to the panel discussion now to hear what experts have to say about these findings. So let me introduce them and our moderator as well. The first is Asaf Bitan. He is an MD, MPH, and the Executive Director of Ariadne Labs, a health systems innovation center at Brigham and Women's Hospital and the Harvard T.H. Chan School of Public Health. He is an Associate Professor of Medicine and Healthcare Policy at both Harvard Medical School and the Harvard T.H. Chan School of Public Health. Dr. Brandon Wilson joined Community Catalyst as Director of the Center for Consumer Engagement in Health Innovation, following his tenure in federal service as Public Health Advisor with the Centers for Medicare and Medicaid Services Office of Minority Health. Dr. Adam Myers is Senior Vice President and Chief Clinical Transformation Officer for the Blue Cross Blue Shield Association, a national federation of 34 independent, community-based, and locally operated Blue Cross and Blue Shield companies. Today, 1 in 3 Americans is covered by the Blue system. And moderating the discussion is Ann Greiner, who is President and CEO of the Primary Care Collaborative. Earlier in her career, she served as Vice President of Public Affairs for the National Quality Forum, as Deputy Director at the National Academies of Medicine, and in leadership positions at NCQA and the American Board of Internal Medicine. Ann, over to you.
Thank you so much, Mark. And it's a pleasure to be here today with this incredible panel. My first question is for Asaf, who works both domestically and internationally to invent care delivery and payment. And he's also an author of the National Academy of Science, Engineering, and Medicine Primary Care Report that recommended that every individual have a usual source of care. So my question for you, Asaf, is why is that important? Why is that not enough? And how do we compare internationally?
Thanks so much, Ann, and it's really a pleasure to be here with you all. And I want to first congratulate Dr. Jabarpar and all the authors of this incredible report. It comes at a very important time in our in sort of the horizon of our primary care system that, like oxygen, you only start to notice it often in its absence. And I think that as we found with the report from the National Academies on Primary Care last year, primary care is critically important and at a critical juncture. And it is well past time. The evidence and the experience of patients, families, and communities who need and want high-quality primary care suggests that we have to give it the attention, the support, the policy focus, the community engagement, and the health system prioritization that it deserves. In terms of the specific question that you have asked really about usual source of care, I guess the way that I would initially answer it is, in my experience, both as a physician, researcher, and health policy stakeholder in domestic and international areas, a usual source of primary care is unusually important. It's the basis, it's the starting point for the creation of long-term healing relationships that are central to the core of how primary care is valuable to people, to families, and to communities. Primary care is a relational enterprise. It's not a set of services. It's not, a blood pressure checkup or well-child visit or a set of immunizations. It is really and the maintenance of a long-term healing relationship. And so it's the floorboard to have a usual source of care. Hard to have a relationship without someone who knows you. The sort of Cheers factor, if you remember the series from the 80s, you know, where someone or where everyone knows your name. Now we know that that's changing in the differential design and spread of new team-based models, but the core of having someone who knows you as a person and for whom you are seen, not just as a visit, a 15-minute object of a transaction, but as a person rooted in your family, your community, your history, your lived experience. The usual source of care is the starting point. It's not the end point. It's really the foundation. And that's why I think that when we think about usual source of care, I think of kind of two directions. Number one, we are nowhere near where we need to be in the US with enough people having a usual source of care. In particular, for those who might need it the most, those who have high complexity needs, those who are older or have comorbid conditions, or who are younger and who have challenging life experiences, psychosocial conditions, and physical conditions. So when we see the incredible variation in uptake and access to usual source of care, that gives us concern. When we see that bifurcated by disparities, unfortunately, in the usual access of disparities, where those who are Black, who are Hispanic, who are poor, who live in rural areas have less access to usual source of care, that's really concerning. And it's really hard to imagine how we reach our collective national, state, and local health goals without improving this. And I think this is the challenge, honestly, that we have to state back to the policy community, to the payer community, to the provider community, and to all stakeholders. It is high time to walk the talk around improving primary care. And that's going to require different types of payment, different forms of payment, and a real focus on improving access to a usual source of care. It's not enough for reports to be published or to say, oh yeah, you're right, and then to spend 3 or 5% of total health spend on primary care. That's just not enough. If you're an ACO, you cannot achieve your ACO goals without a more robust and more accessible primary care basis. If you are a health plan, you cannot achieve your goals without more and robust primary care. If you're a health system, if you're a health entity, or if you're a community, the pathway to the better health and the better health equity that we know primary care provides goes through having a usual source of primary care. And that usual source of primary care is not just any team or any person. It has to be a usual source of high quality primary care. So we have to really insert that quality mechanism. And finally, to your last question of how does this compare globally, we don't do very well. We're second to last in Commonwealth Fund's survey of international performance over 12 countries in terms of having a usual source of care. We haven't moved really the notch on that in years. And that's not a place we want to be for the health of our system and the health of our communities.
Thanks very much, Asaf. I think you've made a good case for usual source of care. And sorry to hear we're so at the bottom. Over to you, Brandon. At Community Catalyst, you have done focus groups and surveys of patients to try to understand what they want from primary care and what they need. When you reflect on the research that you all have done in those conversations, how does that relate to our report findings?
Yes, thank you, Ann. And to lift up some of Asaf's sentiments, congrats on this report. It is very timely. And to your question, it's our research and report are finding some of the same things that you found in this report. Ours highlight the fact that 1/3 of persons aged 50 and older rarely, if ever, have their care preferences taken into account by their clinicians. And more of those persons tend to be people of color and lower income individuals saying so. Our research that we did this year provided the first ever look at how person-centered care models are working or not, particularly for older adults. with that, we compared some data from the health and retirement study, and we found that whether older adults' preferences are taken into account by their providers is heavily dependent upon 3 factors, and that was race, income, and insurance status, specifically. Black and Hispanic older adults were more likely to report never having their health preferences considered in comparison to white adults. And we saw that the disparities are widening over time. Individuals who report that their conditions never account for their care preferences were twice as likely to be low income or below the federal poverty level compared to those who said that their conditions always took their preferences into account. There's a higher number of folks on Medicaid who reported that their clinicians sometimes and never considered their care preferences. We also look at the probability as well as significance levels for impact on having the specific socio-demographic characteristics on the probability of having one's care preferences considered. Those characteristics that were associated with having their care preferences considered were being a Medicare beneficiary as opposed to Medicaid or dually eligible, and having a usual source of care. So having a usual source of care at baseline was associated with about 49% lower odds of reporting that the system never took care preferences into account. But usual source of care, as well as considering care preferences, they're not just nice things to have. It was actually really imperative and central to Asaf's point, a high quality patient-centered healthcare delivery system. We control for demographic, financial, and health characteristics of those reporting never, rating those individuals had higher odds of uncontrolled blood pressure, higher odds of hypertension, and high risk waist circumference. And that's in line with our previous findings that older adults of color and those with lower income had higher odds of higher risk biomarkers. But as expected, those with a usual source of care were less likely to have those high risk biomarkers. A consistent finding from our analysis was the association of having a usual source of care had a range of positive outcomes associated with it. Having usual source of care made it more likely that care preferences were considered. Scores that predicted higher associated healthcare costs, they were lower. There was also a lower likelihood of high-risk biomarkers, and there would be higher levels of preventative care as well as appropriate care utilization. So having a usual source of care weakened association between being a person of color and reporting that one's care preferences were never considered. Let me put that another way. Having a usual source of care decreased the likelihood of never having care preferences considered amongst older persons of color. And the same was true for individuals who had lower income. Having a usual source of care can decrease the likelihood of never having one's care preferences taken into account amongst those who are low income or live with poverty. Taken together with race and ethnicity findings, I think these findings highlight the importance and important role of having a usual source of care in achieving a person-centered healthcare system. So having usual source of care, I think, while accounting for one's care preferences, seem to not only increase access to care, but also quality of care and equity in care.
Well, thanks so much, Brendan. What an important study. And I think it, both you and Asaf have underscored that, we now have a lot of data. Certainly, there's a lot of questions that we still have about the data, but it's beyond time to start fixing this problem. And we're going to get to solutions in a bit. But first, let me ask Adam Myers, who is Chief Clinical Transformation Officer at Blue Cross Blue Shield Association. And he's got a bird's eye view, Dr. Myers does, and what's working across health plans across the country, and also sees the employer perspective. So what's happening between the health plan and the employer to encourage and support usual source of care, and where are there barriers?
Yeah, thanks, Ann. Thanks for the opportunity to weigh in on this. It's a critical topic at a critical time for us as a nation. I would just say that I bring actually multiple perspectives to the table. First of all, I'm a family physician. Have practiced as a primary care physician and understand the realities of both private practice as well as group practice and employed. I have a history of being a physician executive, leading physician practices of up to 7,000 physicians, been a pop health leader in health systems and sort of have that health system, population health, public health perspective. And now on the payer side, bring that perspective as well. And there's a few things that I absolutely know from those experiences. One, as many of my colleagues and this report state, relationships matter. They just do. We're at our core human beings, and we are built for relationship, and care delivery systems really necessitate having relationship in order to be most effective. The outcomes bear that out, in that where there's a usual source of care that functions in that relational manner, outcomes, experience, and affordability are all enhanced. That's it. That's the why. All of those things that we all desire are enhanced. I cannot emphasize the importance and the potential for primary care in this and the relationship aspect of usual source of care. And, what it really boils down to, I think, is that there are three things that people want based on personal experience and the research that I've read from a relationship with their care team. One is they want to feel heard and understood as a human being. They want to feel like they are part of a process of determining their own health outcomes, understanding the physiological issues that they face, and are part of determining the care plan. So shared decision making. And then the final element of it that is really impactful as well is that they're being cared for by a team of people that is communicating with each other and on the same page. I can think of no other sort of milieu in which all of those boxes are checked rather than through a usual source of care such as primary care. Now, we certainly have seen a decline, as the research here suggests, in that usual source of care uptake, and it's certainly multifactorial. But I think the fee-for-service nature of our payment paradigm certainly contributes to that through the transactional nature of it. But to your core question of the sort of the employer lens and then the payer lens, part of what happens in this scenario is that employers understand that their employees want significant flexibility. They want autonomy. And because of that, sometimes the PPO options within their employer-sponsored healthcare have higher uptake, in spite of the fact that they are maybe at greater expense. And the uptake is because there are fewer requirements to access care in that sort of model. However, my personal sense is that some of those requirements are actually good things from the standpoint of requiring maybe a primary care physician as a quarterback for their care and access to specialty care. But it's really that employers are responding to their employees' requests for flexibility and being able to access care when they want it, how they want it, and from who they want it. The issue sometimes with that flexibility is it leads to fragmentation. And I think we've seen that both in the traditional sense, but then also in some of the virtual and other sorts of care that have been brought to bear during the pandemic. They're great. I mean, they're very, very accessible by people. However, they also, I think, because it is not connected, leads to additional fragmentation. And then, I think people really value having a usual source of care when they have it and when they're maybe required to do it, secondary to their coverage paradigm. However, many people really opt for the flexibility associated with other types of coverage, and I think that leads to some of these disconnects.
Thank you so much. I think in the report, we cite a statistic that almost half, 46% of those with employer-sponsored coverage are in PPO. So, you know,
Yeah.
it's a big proportion. You know, you raised up, and now I want to kind of open up for one last question for this group, and then we've got lots of questions in the chat, and we'll welcome back Yalda and Mark. But you touched on it, Adam, and Asaf did as well, that our payment model gets in the way of usual source of care. How much we invest in primary care gets in the way of usual source of care. So I think you all are suggesting that, you know, that changing that may have go a long way to addressing this issue. Asaf, why don't I go turn to you first and get any reflections you have about that particular policy, either at the federal or the state level, and what impact changing how we pay and how much we pay may have on usual source of care.
Appreciate it, Ann, and appreciate Brandon and Adam's comments, and am in agreement with them. Look, I mean, I think that we're at a point where we need to face a reality of the evidence and the lived experience of primary care directly head on. Fee-for-service as a form of payment is anathema to the provision of high-quality relationship-based primary care. That's a big statement because there's big data behind it. There's a whole National Academies of Science, Engineering, and Medicine report behind it. It is not really possible mathematically, policy-wise, workforce-wise, or there's a question in the chat about whether inconvenient access and long wait times drive parts of the problems with usual source of care. At the core of so much of this Gordian knot is a broken payment system that's not fit for purpose, that's more around transactions than it is around relationships. And it's basically, we're hurtling forward in a status quo because it's easy for health systems and payers, and whether they be federal or state or commercial, to pay primary care in fee-for-service mechanisms. But that's not the way that you create relationships, especially in a digital world where you cannot count all the little interconnections in such a way that either promotes long-term healing relationships or promotes the population and total person view needed for primary care. So the payment, both in form, function, and level, needs to change. But you know, the good news is that this isn't going to break the bank. In fact, over a long term, it's probably going to save parts of the bank. The hard news is that that's going to require more than slogans and more than, you know, we should put that on the list for 2026. Primary care will not exist in a form able to care for the populations that it needs to serve, especially in an equitable manner, if we continue hurtling down the road of a form of payment that doesn't work and that essentially promotes, you know, a mediocre visit-based, volume-based provision of what is a much broader lens. So I'm saying it very directly because I think people need to hear this directly, and we need to stop perhaps thinking that there's a false debate. Now, there are many proponents of fee-for-service, but I would have that, I would hold that the evidence is very clear that if we are to build systems of care, and by the way, those systems can be virtual or they can be in person or likely hybrid. You know, that's a form question. That's not a, you know, digital versus analog question. The question that's much more important, in my opinion, is can we build payment mechanisms that incent the delivery of person-centered, population-based relationship care? Or do we want to essentially keep hurtling down the road of a system based on rescue, transactions, and atomized visits? So we have that choice. Do we want rescue-based systems or relationship-based systems?
Thank you, Asaf. Adam, it looked like you were about to speak, and I know you have experience working in a system where primary care had a different payment model. Maybe you want to reflect on that.
Yeah, I've had the honor and opportunity to lead some significant physician groups through some of this transition, specifically in the primary care space. two different opportunities come to mind, but I'll highlight one of them. At Cleveland Clinic, when I was chief of population health there, we had a large group of physicians, many different practices, and it was pretty like 100%. Let's just go 100% into fee-for-service model. And what you found was the typical pattern of people seeing a patient every 15 minutes or so, almost on a treadmill of sorts. Not much time for thought, not much time for proactive panel management. The economics didn't support team-based care. And there was, it actually made it, because the schedules were somewhat by necessity, economic necessity, full, it made access difficult for people to get in when and how they wanted to. We began a transition toward guaranteed payment or upfront payment models. And by the time we finished that transition, more than half of all of the revenue for primary care there was from a guaranteed upfront PMPM payment model in the primary care space. What did that enable? That enabled us to invest in teams where we had behavioral health social workers, pharmacists, other types of team members embedded in the practices because we had the revenue up front. The teams could decouple from that every 15-minute cadence and do proactive panel management together, where they actually had time periods where there were no patients scheduled in the office, and they sat down and said, not just who's on our schedule, but who's on our panel that needs our attention so that we can reach out to them. The change in the payment paradigm led to a care model redesign process that led to better outcomes for the patients, better experience for the patients, greater affordability of the overall spend, and importantly, the practice of medicine turned back into what they desired to go into in the first place. There was that relationship continuity, the rewards were present, and I think it was really a tremendous shift. However, it required at first a payment paradigm shift in order to really empower it.
Thanks so much. Okay, I think we're going to welcome Yalda back to the screen, who's the first author of the report. We're getting questions in, and Mark as well, he's going to wrap things up for us. One question has already been addressed about the convenience care. I think Asaf addressed that. Another, though, is about patients who may have different ideas about what they want from primary care, particularly millennial patients. So who would like, I'm opening that up, who would like to respond to that question? Maybe people don't want this ongoing relationship if you're a millennial and you really don't have health issues.
I mean, I'll weigh in. I think flexibility is important. And however, I would suggest that for people that have any ongoing health struggle, having a continuity relationship, a usual source of care is critical. And, you know, I think there is room within that model for a variety of different aspects of the system, some of which will be virtual, some will be hybrid, as Asaf said. But the critical nature of it is that while there may be different groups that touch the patient and are engaged in the patient, they really have to be connected. The fragmentation of these varied approaches is what concerns me, not their presence. There are ways to connect them and ensure that the flexibility remains, but the fragmentation potential is mitigated. And I think that's part of what we should really look for. And I think the other piece of it is for millennials, the perfect time to engage in prevention is when you're well. When you are well and healthy is absolutely the perfect time to say, how do I ensure on an ongoing basis that that remains my status? And so I think primary care physicians and the usual source of care tend to be the groups that emphasize prevention and being a full determinant in your own health outcomes for your life, rather than just treating issues as they arise on an acute basis.
If I can just quickly
Yeah, go
Yeah, let
ahead.
me just quickly add to that, Adam. I completely agree with everything that you said. And I think to Asaf's point earlier as well, I don't think it's that millennials do not want a usual source of care. I think that the modes by which they go to access and the modes by which they even define quality is different and evolving. For example, I think the millennials completely use Yelp and Google reviews for everything. I think that is also one way of getting information about who's the best PCP, who has the most flexibility, who allows times that are preferential to my lifestyle. So I think all those things have to be considered as well. And I don't think that says or at all eliminates the need for a usual care.
Yeah, good point.
Yeah, I would add also one more point, which is that if you looked at the data, that young people are 6 times more likely to have a usual source of care than adults. And so what's happening is that they're seeing their pediatrician or their family physician in their early years, and then we lose them along the way. And so I think there's an opportunity for that handoff to be better, for them to move through adolescence with a continued usual source of care and then onto adult medicine in the same way, so that sort of primary care prevention experience that they're having with their pediatrician when they're very young continues on through adulthood. And that's going to require a number of changes on all sides in order to make that handoff, so that you think about having that same kind of usual primary care experience that you had as a child all the way through your lifetime. That's a paradigm shift that is going to need a lot of different drivers as well.
And I think another piece of it is that the usual fee-for-service compensated primary care model in the traditional sense doesn't have the flexibility to meet the expectations for access, oftentimes doesn't have the flexibility that millennials desire. So while they may want that, they seek care elsewhere because the flexibility is critical to them. And if there's a way to, through payment paradigm shifts, team model-based care shifts, to morph the way of traditional practice to be something new and different that has that flexibility associated with it, I think there'd be more embracing of the usual source of care during those middle years.
Yeah. Well, another thing that has been brought to my attention is it is the access and convenience, but it also may be the kind of services that are rendered. So we know that young adults are struggling with mental health issues and maybe substance use issues, or trying to get on top of a healthier lifestyle and could use some coaching around nutrition and exercise. Well, those are the services that under a different payment paradigm where you were really responsive to what your patient needs are, and you had a team you could offer in your practice, and that would benefit us as a country long term, because people's the array of people's issues, whether they are physical, mental, or social, could be addressed earlier on, and perhaps we could mitigate downstream effects. Let me see if there's any other questions, and then we're really getting close to closing out here. One question that came in is, again, back to payment. And you have many of you have made the case. I think everyone here around our virtual table has made the case for a very different payment model. One person asked, though, people are often comfortable with what they know. Most primary care clinicians are still paid fee for service, and may not be really comfortable transitioning to new models. So how do we catalyze that change? How do we work with primary care clinicians to demonstrate that going through this, getting to the other side, they may really, in fact, enjoy this new model of care?
Well, I can speak as a clinician, not as a researcher here. I think primary care clinicians in general believe in taking care of the population they serve. We believe in the relationships, but we believe in taking care of the population we serve. I think the scary part is if your salary is somehow based on quality metrics that are often tied to these capitated models. But, you know, our data has shown that most primary care physicians, clinicians are employed at this point. So how do the health systems ensure their clinicians that while you're trying this capitated model out, you know, where your salaries are staying stable, we're going to provide your teams the resources they need to manage your population. All of that, I think, would go a long way.
Yeah, I would just add that it's, you know, I think that guarantee is really important. I think that gets it to the issue of investment. I mean, there at some level needs to be some marginal or more than marginal extra investment, often in the form of guaranteeing salaries, but also, for instance, we've seen systems across the country, payers across the country guarantee a capitation system at, let's say, 110% or 115% of last year's primary care spend. Now, that may sound horrifying to the payers in the room, but remember, you're only spending 3 to 6% of your total spend on primary care, and so many of your goals. And we see your goals in your annual reports and in all the conferences that we're going to. We share those goals around population health, around health equity, around improved quality. This is a good, smart investment. By the ability of primary care teams to relate and to be in better relation to their team, to their patients and communities, instead of helping hospitals spend a few more $1 million on scanners or on other imaging or other tests that are of maybe middling or no value. I mean, I think we have to have these hard conversations in order to make clear the point that the report is very clear on. Primary care is not a charity case. It's a must-have. And as Brandon's research is showing, this is what people are expecting and needing in terms of their preferences to be able to ward off and care for themselves and stave off downstream conditions. So this is a smart investment, but it has to be prioritized.
Okay, over to you, Mark.
Well, gosh, unfortunately, it is my job to end. This has been an excellent discussion. Thank you very much to all of the panelists who have participated and for everyone who helped us write this important report. The report is available on the website. Read the whole thing. It is really much more than we could cover in 1 hour today. But the importance of primary care in the lives of people, if we're going to get to our shared values about the health and well-being, both in behavioral, mental health, as well as physical health, we can't get there unless we can figure this out better. I want to close also by inviting people to come to our conference in December 14th and 15th. The PCC is going to put on a great meeting. It's called Better Health Block by Block, and so hopefully all of you can come. Registration is on the website. There's still spots available. So thank you, Ann. Thank you, panelists. Thank you, everyone who helped us write this report, and I hope you all read it and have a good rest of your day. Bye-bye, everybody.